Welcome to the Central Mass Podiatry All About Bunions. This talk, we are going to probably spend about 30 to 40 minutes going over bunion questions and going over any issues that you may have. My name's Don Pelto. I'm been part of the practice here, I think 10 or 12 years. I would do the intro and kind of the emceeing of the event. Dr. Feldman's going to talk about what causes bunions. Then we're going to talk about shoe choices and some non-surgical options with yours truly. The bunion surgery, Dr. Saviet's going to talk about that. Recovery and recurrence, Dr. Kellner, and then questions. And as Dr. Feldman said, if you guys have any questions during the course when someone's talking, feel free to write a question. We'll either answer it at that time or at the end. There were about 10 questions, so that's pretty good. About 10% of people asked us questions about bunions, and we may answer them throughout our talk, or we may answer them at the end. And I would like to start here with Dr. Feldman. Welcome.
Thanks, Dawn. Welcome, everybody. Thank you for sharing your evening with us. What causes bunions? A big part of it is genetic. On the screen that you're looking at now, I am keeping it close to the family. This is my daughter. On the left, it was when she was 11. And on the right, it's current as a 17-year-old. And Don, point to the growth plates on the left-hand side. So this is a growing foot. And in my daughter's case, you can see this long, big toe that's sticking kind of straight out in line with the metatarsal. And it's a nicely shaped foot. And if this little foot is allowed to grow without any interference from shoes or anything else in life, it should continue to grow straight. And now 6 years later, this picture on the right, you can see the growth plates are now closed. And the foot, for the most part, is just a bigger version of the one on the left. If we advance it one screen, now on the left is my daughter's foot, and on the right is my wife's foot, many, many years later. Now, genetics are such that oftentimes the children inherit the feet of their parents, one or the other, or sometimes a combination. In my own children, my son, unfortunately, kind of has no chance because he is either going to have my feet or my wife's feet. So he's got my feet with my wife's sort of flimsy toenails. But my daughter is completely my wife's foot. And my daughter had bunions at the age of 9. And you can see a screw and a pin, the picture on the right, because she did have bunion surgery about 25 years ago or so. But she had a very large bunion at the age of 9 because when her foot was little, she was put in a traditional shoe, something like you'll see in the middle, where the toe box tapers. It comes to a point. And when you take a little foot and you let that little foot grow into a big foot in the confines of a shoe, the shoe is going to completely distort the growth. And you're going to end up with a bunion at a very early age. Right when there's imbalance at the big toe joint, and it's the imbalances with a foot that's still growing, the imbalance can only get greater. On the left-hand side, Don, circle the sesamoids. So the key with my daughter's foot is those two little circles underneath the metatarsal are perfectly centered under the metatarsal. And that's really the key, because if we can keep those bones centered under the metatarsal, the foot should develop normally. On the picture on the right, after surgery, you can see those two bones are to the right of the metatarsal. The goal of the original surgery was to move the part of the joint where Don's circling over the sesamoids, and it worked for a couple of years. You're going to see some surgeries later in the presentation where we try to get the metatarsal over those sesamoids to rebalance the joint. And I want you to think of bunions not so much as something that is a bump of bone. It's really an imbalance of a joint. If it was your knee, it would almost be like your leg's coming down straight and then the lower leg is coming off at a right angle or a 45-degree angle. If you were to walk like that, you'd have a big lump on the inside part of the knee because of the imbalance. A bunion is nothing but a joint imbalance. And again, when it starts young, it can only get worse. So the key is to not let it develop. That's the best way to treat them. Most of the people on this screen, actually everybody on this webinar is a little bit older. Their feet are fully grown, and you already have bunions. So it's almost a moot point at this point to talk about the causes of bunions. If we could build a time machine and go back in time, or if you can go to grandchildren at this point and prevent your own kids from making the same mistakes that our parents made. Then we have some chance to avoid it. But the bunion causes are really genetic. This is another picture that shows the fact that we really should allow the shoe to fit the shape of our foot and not the other way around. We don't want to make our feet kind of conform to the shape of the foot. We'll get used to it, but it's not the way it should be. This is another person who you can see growth-related deformities. This is one person. This is her right foot. She's now 16. So on the far left, she was about 13 years old. You can still see the growth plates. We have an angle of 12 degrees between the first metatarsal, which is the big one on the left. Don, you want to just line up the first metatarsal and the second metatarsal. The bigger that angulation, the greater the bunion's going to be, because the big toe needs to stay in line with the first metatarsal. So Don, just to highlight I don't know if, actually I can do this. So can you see me or no? Do I have access, Don, or no?
Yeah, you can, I think, yeah, you can move it, I think.
Can you see my my mouse pointer or no?
No, I don't think so.
Here, Don, just move the mouse up and down the big toe.
On the big toe right
On
here?
the left image. Yep. So we want that big toe to be in line with the metatarsal, but you can see at 13 years old, it's already deviated. So she's already got a joint imbalance, and that sesamoid bone is already peaking in between the metatarsals. We go several years later, and that angle went from 12 degrees to 13.5 degrees, and the foot is more fully developed. The growth plate is closed, so now it's time we can operate. And on the far right, you can see a surgery where we cut a wedge in the bone and reposition the metatarsal directly over the sesamoids, and now her toe is very much in line with the metatarsal. So you have the influence of shoes, and you have genetics, and that's essentially what causes bunions. And so, thank mom and dad, and they can thank their parents, and so on and so forth.
Good job, Dr. Feldman. I'm going to talk a little bit about shoe choice and some of the non-surgical options. Many of our patients and many of the questions we got were about ways of preventing surgery. And that's what we are very good at, is trying to avoid doing surgery. But one of the biggest challenges, like Dr. Feldman said, is trying to find what types of shoes that will work, and if you're willing to wear those types of shoes to try to prevent them or prevent them from getting worse. The first test I like to talk to our patients, and we all talk pretty much the same way, is something called a shoe liner test. You can see this picture on the left. It's kind of busy, but it shows a couple of techniques that can help in preventing a bunion from getting worse. I wouldn't say it can actually cure a bunion. I know the inventor of correct toes thinks he might be able to do that, but I'm not too sure. And what you're seeing, so these are toe socks. These are toe socks. Just wearing a toe sock in general can sometimes spread out your toes a little bit, and it can feel good. This is one brand of toe socks. These things that are on the toes are something called correct toes. And the more toe spacers you have, the better they work. If you only use one, sometimes it's not strong enough to correct anything. These tend to work well with our patients. And then specifically, you can see that their foot is on top of the sock liner underneath. And that's called the shoe liner or the sock liner test. And when you step on the liner in your shoe, you should be able to see all of your toes. Your bunion shouldn't go over the side of it. Your toes shouldn't go over the side of it, because that shows that it's a little bit too narrow. And like this picture that Dr. Feldman showed before, this is an appropriate fitting shoe. It's what we call anatomic. Anatomic doesn't always mean a wide shoe, because if you buy a wide shoe, a lot of times it's wide in the front, but it's also wide in the back, so your foot slips around in it. That's why a wide other brand of shoe might not work. There's a couple of brands that are really well known. Some are Lems or Ultra or Vivo Barefoot, and we can certainly send these to anyone that want to know. And I'll actually include it in the post email for this lecture, some of these other brands, if you want to find some of the shoe vendors. So the first test is the shoe liner test. So you take your liner out, stand on it, and if it's your foot's not wide enough, or if your shoe isn't wide enough according to the liner, you might need a more anatomic shoe. If something gets really inflamed, I know no one likes to look at needles, but we occasionally use needles with cortisone injection to calm down the joint if it's inflamed. We don't do many of these. It's not like you come in every 4 months and calm down your joint. It's once in a while, one time, or I don't really do more than one. I don't know if you guys have. You guys can chime in here at any time. I'll do cortisone if it's really inflamed, it's really red. Usually someone's doing a lot of activity, and that will calm it down. Someone comes in thinking they might need surgery, and we can do a cortisone and calm it down, and they're totally fine. They just wore a bad pair of shoes, or they went to an event or something like that. So that's when we would use a cortisone. There are different types of pads. Some of these pads, they protect the side if the side rubs on the shoe. Now you have to be aware, if your shoe is too small and you're wearing a pad like this, it's actually going to take up more room in your shoe, so it might not be the best option. The shoes are really the best option. Here are the correct toes, and here's a single toe spacer. And as we were talking a little bit before, Dr. Feldman mentioned that just a single toe spacer, it doesn't really do much. It spreads it out, but it doesn't have much force to have any prolonged effect. Whereas the correct toes, and these are made to wear all the time in your shoes and even outside of the shoes, walking around it in the house. It takes a little bit getting used to these, though. These are made of medical grade silicone, and they really help our patients. And those that want to try them, they work well. And the last thing that can help our patients, and this isn't so much to, once again, make a bunion go away. Once you have a bunion, it's really hard with these non-surgical options to make it go away. We can maybe make it more comfortable for you with a cortisone or with a pad or an anatomic shoe, but we can't, reversing it's really hard, and they tend to progress. Some of the ways to help it avoid progressing would be the correct toes like we showed you, and then orthotics can be helpful. There are certain things that we do to the orthotic, like if we want to give more range of motion, we can cut out a portion underneath the big toe joint to allow the joint to move a little bit better, or drop down the bone a little bit. Or there's something at the tip of the big toe. I know Dr. Saviet, he introduced this to the practice where we're adding these to our orthotics. It's called a Cluffy wedge, where it helps the range of motion. Because sometimes, as someone asked in one of the questions, there is a joint arthritis a little bit, or the joint doesn't move as well. The technical term is called hallux limitus, but something like this can help the joint to move a little bit better and make it a little bit more comfortable. Also, an orthotic that stabilizes the heel and contours well to the arch can help as well, just to, as Dr. Feldman talked about, a mechanical, like an instability of your foot, or mechanical. If you can stabilize the mechanics of your foot, a lot of times it can make it not progress as much or not hurt as much. So those are a couple of the non-surgical things. We're going to get into Dr. Saviet, and I'm going to talk a little bit about bunion surgery.
All right. So importantly, when people show up for discussion about their bunion, they usually say, like, I have pain on this bump. And in their mind's eye, they tend to imagine that there's just a big lump of bone over there. And I think Dr. Feldman touched on it briefly there, but it's important to know that that's not just a lump of bone over there. It's that one of those bones is fully deviated from where it ought to be. So on the next image, there's lines that are down the middle of each of those bones. So your first metatarsal is on the left, your second metatarsal is right down the middle. We draw 2 lines, and then we measure the angle in between there. And that allows us to kind of grade out a bunion. So the smaller that number is, so anatomic, no bunion would be around 4 degrees, somewhere in that range. Someone who has a bunion, you're already looking at something over about 8 degrees. And these go up precipitously. Like, the worse the bunion, the bigger the number, generally speaking. And then there are sometimes some other conditions that are underlying that you'll see on one of these slides in a minute, that are, it looks like a bunion from the top, but once you see the x-ray, you go, holy crap, there's a whole bunch more here. And in this case, this is sort of like, not necessarily a beginner's bunion, but it was a very mild bunion, somewhere around 10. These are, there's a lot of these roaming around out in the wild. And the way we fix this one is we do it with a bone cut about around the further third on the bone. We cut the bone, we shift it over, and we stick it together with 2 screws. And you can see we reduced that number to somewhere around 6. These were just rough estimates on the angular measures. Now, the other complaint for this woman was she was complaining of the bunion, but also had a very wide forefoot. So the simple procedure for that 5th metatarsal is you can just shave off. You can actually do that to the 5th metatarsal. I do not advocate that for a bunion correction for anyone unless they're basically bedbound and a couple footsteps away from the grave. That would not be a great bunion correction for most folks. So think I have the lateral projection too. Yeah, so you can see what those two screws look like when they come through the bone there. You can actually see the bone cut there on that lateral image. Donna, can you show it was a calish on the right side. Can you show that? Yeah, there you go. That's where the bone cut is right there. And those two screws fixate that in place. So then the next bunion we have is sort of a bunion that wasn't all that bad by angular measurement, but once we don't have x-ray vision as doctors, but once you get the x-ray, you can really tell a full story about what's going on with this bunion. And in this case, compared to the last bunion, you can see how bad that big toe joint is. So it's been malaligned for so long and not moving in the direction that it should for so long that she totally destroyed that joint space. So in her case, rather than trying to just fix the bunion, we fixed her arthritis at the same time. And the way we did that is we kind of finished the job that nature had started, and we just fused her big toe joint. Now, this woman in particular, I like her a ton. She didn't let that stop her at all. She's great. She run a big toe joint fusion is a serious procedure. You're off your foot for 5 weeks, but when you're done, you can walk comfortably, you can run. She's running 5Ks and 10Ks and doing very well. She had some other stuff going on with an injury to her second toe. That first surgery I showed you there, the previous patient, that's a surgery that you can weight bear on immediately in a walking boot under most circumstances, as long as you behave. In this case, this bunion correction to fix the arthritis as well, you're off of this for about 5 weeks. Now, the worse your bunion gets, the more significant the recovery tends to be. This is that same person again with the big toe joint fusion. So now we're going to an even bigger bunion. And you're starting to see those angles are increasing. So now we're up around almost 19 degrees. That's a pretty significant bunion. This actually tends to be right in the wheelhouse of the types of bunions that I get all the time, because everybody else in the community doesn't want to touch them and they send them to us. And if you can also look at her x-ray on the right-hand side, on her third metatarsal, she had a stress fracture. When these bones are unstable in the sort of left to right direction, as Dr. Feldman was showing you, they're also unstable in an up and down direction. So as a result of that, you tend to see overloading of the bones next to it. So she managed to skip her second metatarsal, but she fractured her third metatarsal there.
Hey, Ben, Don, just go back one slide. Go backward. And then, Ben, just comment on the lower slide. Look at that second toe floating, because people should understand that when you have bunions and arthritis, they're often not in isolation, and it really creates a lot of instability to the rest of the foot. But this is a great example of what happens.
Yeah, so she totally blew out the ligament that holds her second toe down. If you go back to the AP, Don, yeah, so that construct up there, there's a button-based anchor and an absorbable anchor in the second metatarsal that basically it makes an anatomic version of that ligament to hold the toe down. So it's a nice stable toe for her now long term. But that developed because of her bunion and her overloading that second metatarsal joint, that second toe joint, basically. So this is a super common bunion that I end up correcting all the time, somewhere in the like 15 to 25 range. And you can see how rather than going and cutting the bone up halfway along the shaft, you wouldn't get a very good correction, and you're not going to correct the instability. So you have to go correct that at the base. The analogy I use in the office a lot is if a contractor came into your house and you had a tilted wall, and they said, oh, I'm going to cut that wall at waist height. I'm going to push it over and I'm going to put some rebar behind there to hold it together. Well, that's fine if you don't intend to live in that house for very long. But if you're going to be in that house for the rest of your life, you want the contractor that's going to come and fix that tilted wall at the foundation and put it back and keep it stable so that you can live there for the rest of your life. So that's what this surgery is. We go and we sort of sacrifice a joint and stiffen that joint right there and put a screw and a staple across it. It's really minimal fixation, which is great. But this is something that you're off your foot for 6 to 8 weeks before I let you, before you walk on it. All right, and then the next one. This is a foot that I just like to show you how bad some people let their feet get before they come in to be seen. Super nice woman. She's a nurse. She just never had time to get her foot fixed. on the image on the right, the yellow angle sort of shows you how that angle can lie to you. So it says it's a 14, but her first metatarsal is so far off to the right that it's off from the long axis of her foot. So the real measure of that angle is probably somewhere around 33 to 40. So that's a crazy big bunion. That looks like her big toe joint is trying to hitch a ride, like she's hitchhiking all the time. And she had other deformities as a result of that. She has a ton of arthritis in the middle of her foot because that first metatarsal is so unstable. She just kept loading through joints that weren't supposed to be loaded until she developed arthritis through the middle of her foot. So she ended up with one of my favorite constructs, which is screws and staples through all 3 of those joints in the middle of her foot. And you can see that all of those bones line up a lot more straight now. And she has a foot that can actually fit in shoes. And we corrected the position of her big toe joint so it sits on straight. We corrected her hammer toes. This was a big surgery. This took me, I think, 3.5 or 4 hours to do, but she has a totally different new foot. And that sort of shows you the spectrum of itty bitty bunions all the way up to pretty big bunions. And the level at which you have to do the correction kind of varies on the bunion, and what you do to correct that bunion kind of depends on the bunion itself. You guys have any other comments on surgery stuff there before I? Big bunion, this woman was off her foot for 8 weeks.
Very good, Dr. Saviet. Thank you. Thank you for sharing those. We go back and forth in the office and look at these. So very good. Dr. Kellner, I'm going to have you talk a little bit about the recovery and recurrence. That's what a big concern of patients. How long is the recovery and how hard is it? And what's the concern of having them come back?
Sure. So definitely very important to talk about what comes after your bunion surgery and make sure everyone understands what to expect and also set your goals. So first, looking at the healing time, kind of in a chronological order, we'll look at the skin incision and the soft tissues. That typically takes about 2 weeks to heal. So you'll have a follow-up in 2 weeks, and that's when the sutures will come out. And then looking at the bone procedure, if there is a bone cut or a fusion, bone healing typically takes 6 to 8 weeks overall. So it's important to give your foot that time to heal itself. And, based on the bunion procedure selected will be, how long you're off of your foot. If you're doing a very simple bunionectomy, if you're like Dr. Saviet mentioned, just shaving the bump off, which we don't often do, but it's possible, you can walk on it almost right away. I typically tend to wait until at least the incisions come out before I have anyone walk. But if there is a bone cut or a fusion involved, you can expect to be off the foot 4 to 6 or sometimes even 8 weeks, depending on the procedure. So that kind of covers with the non-weight bearing period as well. There are many different ways to stay off of your foot, more than just crutches. So it's also important to evaluate if there's any kind of shoulder issues for crutches. On the left image, I always mention the eye walker. That's kind of allows you to walk with a peg leg sort of assistance, and then, or we often recommend a knee scooter on the right, which is very helpful and definitely easier on the shoulders and joints than using crutches. When it comes to recovery, if you are off of your foot for a long time, say it is 6 weeks of non-weight bearing, you certainly will have some weakness in that leg. Physical therapy isn't always absolutely necessary as in terms of a formal referral, but there definitely is some at-home physical therapy you'll definitely need to go through. When it comes to the procedure selected, if there's been a bone cut of the metatarsal and there wasn't any joint fusion, it's very important to keep the joints mobilized. And I'll have patients, doing at-home physical therapy, doing range of motion of their great toe joint as early as 2 weeks, to make sure that there's not too much scar tissue buildup. And because the range of motion is really what helps you, walk. When we walk forward and we roll off our big toe, we need that upward motion of our big toe. In the other case, if there has been a joint fusion, the goal isn't to restore any motion, as we took the time to eliminate that painful motion and correct the deformity. So overall speaking, in terms of full return to activity, it depends on what your goals are. So it's definitely important to set those beforehand, whether you're a walker, a runner, a swimmer, biker. You can, I on average say up to 3 months for full return to activity though. They could always be a little bit quicker if you're more fortunate, or a little bit longer in terms of residual swelling and stiffness and things like that, which can of course be worked on. So.
Very good. Did you want to talk a little bit? There's been a lot of questions about recurrence, and maybe we could have some of the other doctors chime in too. What's the recurrence rate? How often do they recur?
I think going by the literature, the recurrence rate is somewhere around 5%. However, I think that if the correct procedure is picked for the correct bunion, you can certainly minimize the recurrence rate. For like Dr. Saviet mentioned, you have that very severe bunion and you go ahead and chop it at the waistline, it's certainly not going to last and work out for you for life.
Mm-hmm.
If you do a more proximal fusion, as he showed in the last 2 cases, that's usually pretty permanent, but there is risk of recurrence, and that can happen in as early as 1 year or 5 years or 10 years, but hopefully never.
Correct.
It's really important. It's really important to understand where the deformity is actually coming from. And because again, it's a joint imbalance, not just a bump of bone. In the earlier pictures, when I showed my wife's foot that had bunion surgery, she has a bunion that came back because she should have had the surgery done in a different part of her foot. Her bunion was back in about 6 or 7 years, and it's 20 something years later, and it's not quite as bad as when she first had it, but it's pretty bad. Sometimes the knee position, the hip position, somebody's posture can affect it. If somebody has a really beautiful bunion correction and they go into pointy shoes while the foot's still healing, then you can get that imbalance to come right back. So there's a number of factors why surgery would, or why bunions would return even after surgery. Sometimes they're not corrected enough. And sometimes they're corrected perfectly on the table, and then right when somebody's walking, the forces of how they walk in general, and again, like that's knee position, hip position, posture, and movement, has supreme influence over the foot. The foot is ultimately just a puppet on how the body moves over it. So if movement isn't really even and nice, then you could get a bunion back again. But the key really is fixing it at the source of where it's coming from. And Ben's x-rays sort of showed those corrections in the midfoot, which is where those large bunions or bunions that are very flexible need to be corrected. When you go in and you have an opinion from surgery and it doesn't look like you have a very large bunion, and the surgeon says, well, we can do a surgery and you'll be in a walking boot for about 3 weeks, and then you'll be back in shoes afterwards and everything will be good in 2 to 3 months. That sounds really appealing, as opposed to, well, it's not a big bunion, but it's a very unstable foot. So let's do a surgery where you're off your feet for 2 months in a cast, and then it's going to take you a month to get back into shoes, and the recovery might be 4 to 6 months. Nobody's really going to choose that one, but that really is the better surgery for the vast majority of people. So you have to have some foresight and some planning and understand not just what's best for now, but what's best forever. And that's the discussion you have to have with us or your doctor, whomever you see.
So there's some great points, Dr. Feldman. We've been trying to answer a lot of the questions on the chat that have been coming through. Certainly, if anyone has other questions after the fact, I would recommend, contacting one of us, and we'll be happy to answer more. I wanted to go through the 10 questions that were asked prior, just so I get through those, and then we can answer any other ones. We also want to respect everyone's time here. So I'm going to divvy these up here. Question 1, I've had an injection for my bunion some time ago. However, recently it's been acting up, painful and sore. What would be my next option for treatment? Another injection, surgery, etc.? Dr. Saviet, would you speak to that?
I'm not a big injection guy for bunions. I think sometimes what we're injecting for a bunion is basically a little bursa, which can be a little fluid-filled sac along that side of the big toe joint. If someone, which can calm it down and calm down the inflammation there. If you repeatedly get a cortisone injection for a deformity, you're going to eliminate your pain signals, which tell you, hey, stop doing something because it's hurting you. And the other thing that cortisone can do is it can weaken those tissues. So I have seen people who got repeat cortisone injections over and over and over again, thinking that was going to solve their problem without solving the actual problem. And then they end up with a worse deformity because soft tissues start to fail. So I'm kind of if you're going to get an injection, you'll get one and you're done. For me, I think other folks are more willing to do that because some docs are people pleasers and they want to try to make their patient happy when they walk out the door. But ultimately, a patient should be happy with the better long-term outcome, in my opinion. So depends. It's probably an X-ray to evaluate the extent of the bunion deformity. Sometimes it's shoe changes at that point. Sometimes it's an orthotic if that hasn't been tried. But once it gets to the point where it's not controlled, it's affecting your quality of life, that's usually when surgery becomes part of the discussion.
Perfect. Good. I agree. I don't do that many cortisone injections. I mentioned it just because if it's really painful, sometimes one can help. Question 2. How does arthritis cause bunions, and what are the non-surgical treatments? Dr. Feldman, you want to answer that? Talk about arthritis?
Yeah, actually, I just did a comment to the group. So because a bunion is actually a joint imbalance, again, let's use that knee as an example. People would understand that if your leg comes down and your lower leg angles off, so your knee is distorted, it's pretty obvious that your knee is going to become arthritic. You're going to wear out one side of the joint over the other. The big toe is no different. When the toe is angled or deviated, you're going to wear out one side more than the other. Once the joint gets worn out, that's arthritis. There's different levels of it. The picture that you have on the upper right of the screen, Don, that's really bad arthritis. That's almost a fused joint because there's no cartilage left. There's a lot of extra bone that's formed. Because once the joint deteriorates enough and you're still trying to use that joint or stuff that foot into a shoe where the toe is being pushed over, or doing exercises that force motion through the joint that's the joint can't possibly use that motion, then the cartilage is going to wear out. So most long-standing bunions are going to have arthritis either at the joint level where the bunion is, or the joint behind, where in some of Dr. Saviet's pictures where the screw and the staple. And oftentimes it's the instability where your arrow is now at the joint behind that allows the bunion area to get out of position that creates the arthritis in that joint. So we always look at arthritis when we're assessing bunions, but they're part and parcel. They coexist.
Perfect.
And before you walk away from that, sometimes obviously that's an end stage joint. There's nothing you can do but finish the job that nature has completed there. There are times when you can do a bunion surgery and fix the bunion, but also what's called decompress the joint, where you basically make a little bit of extra joint space in there. And that can preserve you and keep you away from a fusion for an extended sometimes 5 years, sometimes 10 years, sometimes forever. So it's worth considering some of the time that, sometimes you should strike while the iron's hot to correct a bunion before arthritis gets there.
Mm-hmm.
I'll answer the second part of that question too, the non-surgical treatments. So arthritis, and there's a huge spur of bone, Sometimes we just go after the big spur of bone because in some people it can actually create sores in the skin. It can create impossibility with wearing shoes. So there are occasions where we'll just take a very simple approach and smooth something, but then you want to manage the arthritis. So arthritis is a joint that doesn't move well. So if you understand that and you're able to not force motion through that joint, then you're going to feel better. So that means getting into the right shoe, maybe making an orthotic that stiffens up the joint from the outside instead of the inside with a plate and screws. But it's all about trying to understand what bothers the foot, what bothers the joint, and seeing if there's a workaround so you can still do the things you want to do in life without bothering the joint. Simple things that nobody thinks about would be push-ups or gardening or going down the stairs. These are things that are really hard on big toe joints that don't bend. So it's not like what you can't garden or you can't do a push-up or a plank or walk down the stairs. You just have to maybe change how you do it. There's always ways to figure it out or work around it. It just, they might not be intuitive. And sometimes we just have to point it out.
Perfect. Let's go on to question 3 here. Dr. Kellner, any downside to letting a severe looking yet usually pain-free bunion go untreated year after year? It starts to ache a couple of times a year, which is relieved by wearing a brace overnight for a couple of nights.
When it comes to, I mean, looking at severe bunions, cosmetically, oh, maybe I need this done, maybe I need this fixed. I think when it comes to surgical evaluation, that, I go for treating pain and treating symptoms. And if the bunion is causing difficulty, even with fitting in shoe wear and such and rubbing, then it's a problem. If it's pain-free, I would just go for, accommodating the bunion, such as wider shoes and maybe orthotics and maybe occasional steroid injection if you needed it a couple times a year at most. But I wouldn't seek bunion surgery just simply for cosmetic purposes, if that answers your question.
Yeah, if I could chime in, I have a little three reasons I would do a surgery. If you can't find shoes that fit, if it hurts all the time, and then if it's developed in like an ulcer or a wound from rubbing, like those are reasons I think to fix most surgical things. Question 4, does Medicare routinely cover surgery for bunions? And if not, what's the ballpark all-in cost? Usually Medicare does. Usually insurances, they consider this, it's not a cosmetic surgery. I'll just chime into this. So most insurances, you may have a deductible or something, but for the most part, it's covered by insurance. I don't know if Dr. Feldman wants to mention anything else, but it's usually not an issue.
Yeah.
Ben, go ahead.
I forgot what it was. Who knows? Gone now.
Actually, there is some specific plans that, for whatever reason, they don't cover bunions. It's actually a specific exclusion. There's one very particular Blue Shield plan. We've had this happen. So I would contact your insurance carrier. Medicare does cover it, but I would contact your insurance carrier and see if bunions are a covered surgery.
Yeah. Question to all the docs. Do you think toe spacers help at night?
It depends on what you're asking them to help with. So I think of like the toe spacers at night to be more like traction, give the toes a little bit of a break, realign the joints. And as they're at rest, hopefully it can relax the ligaments on each side of the toes and give the joint a little bit of relief. It's not going to do anything to correct the bunion.
Mm-hmm. With the exception of
you want to, what was that?
When you say with the exception of kids, once you're no longer plastic, you're kind of stuck.
Yeah, but it's, you want to correct it in the weight bearing position. You want to, if you're going to use spacers to correct a bunion, you got to have your foot loaded. You got to be standing on it and using it in shoes. If you put spacers on at night and then you're in bad shoes that don't fit and squeeze the toes together, the spacers at night aren't really going to do anything.
Yeah.
But it's one of those things where if it's comfortable, do it. There's yoga toes. There's the toe alignment socks. There's plenty of options. The correct toes are good options, but I like the correct toes better with the with shoes during the day as opposed to at night. And sometimes if you're going to wear those during the day, you really don't want to be sticking things between your toes at night. Sometimes they just need a break.
There was a question previously someone had asked about, do you guys know of any strengthening exercises? Can you do like intrinsic strengthening exercises to help bunions, or I don't know, any experience with that?
Yeah, so I do recommend a lot of people do toe exercises. There's something called toe yoga. We share links with patients on that. There's two sets of muscles that impact the foot. One set of muscles starts in the lower leg, and they become the tendons that move the foot. So if you pull your toes up or you pull your toes down, those are the bigger muscles in the leg that are creating that movement. And then there's smaller muscles in the foot. They're called intrinsic muscles, so they're intrinsic to the foot. And those are the stabilizers. And when you develop bunions and hammer toes, it's typically because of an imbalance where the movers, the bigger muscles that start in the leg, are overpowering the stabilizers. So what we try to do is we try to reposition the toes by using things like toe spreaders and making sure people are in the correct shoes day to day, but then also reinforce that position through strengthening by learning how to develop the musculature in the foot that can keep the toes stable. So sometimes we use a hacky sack to strengthen the toes in the downward position, and then the toe yoga can work on creating some dexterity between the big toe and the smaller toes. Some people have that ability, some people don't. My toes are pretty much dead, and doesn't mean I shouldn't try, but some people are really able to spread their toes just like that. And but you should try it. Like, so if you try to spread your toes, sometimes what happens is they extend up instead of out. And that's the impact of the bigger muscles in the leg on the foot. So if when you try to spread your toes, they go up or they go down, that's because you don't have strong enough intrinsic muscles. And those are people that probably could develop better foot strength to somehow limit the worsening of bunions.
That's great. We've answered some of these questions, so I'm going to go through them pretty quick here. What's the best way to avoid bunions? We addressed that. Are they inherited? Definitely. We talked about that. Neil showed his family. So
choose better parents.
We talked a little bit about this as well. What's the downtime for surgical repair? Anywhere, depends if the bone is cut, for 6 to 8 weeks. I like this part. How long after surgery until a patient can wear high-heeled shoes again? I'm going to fix it so I can fit into high heels, 6 to 8 weeks, right?
Well, remove the big toe, then you don't have to worry about it. It'll be a lot quicker.
Approximately, what is the time frame recovery? We talked about this as well. This was this is just a symbolic picture here. Is there anything that can be done for the second, third, and fourth toes that are getting squished by the turned big toe? So Dr. Saviet, can you talk about when the little toes get squished by the big toe? Is there anything else that you can do?
Yeah. So it depends how old you are. If you're in your 20s and that's happening, then there's no way I tell you you're letting me fix your second toe without fixing your bunion. I always say the big toe is a bully. It's going to push those little toes around, and if you don't stop the bully from beating everybody else up, you stand no chance. If you're an elderly person and your big toe is horribly deformed, like that picture on the right, all the way to the right, sometimes the path of least resistance to keep an elderly person walking is to simply amputate the second toe, which I know sounds barbaric, but it is an easy recovery. It is going to heal very well a lot of the time, and it usually solves the problem of crowding. But it's pretty permanent, and you can't really get it back. So that's a commitment that we like to make sure you're okay with. And I've had people opt for it. It's a very easy recovery, frankly. So depends on the person.
Perfect. Any suggestions to address pain in that joint, but not from being in a shoe? So if someone's having pain in the big toe joint, but it doesn't really hurt from a shoe being too tight or anything like that. We talked about that. We could cortisone injections.
I would circle back to Dr. Feldman's recommendations about don't put abnormal excessive forces through that big toe joint. Don't do lunges that force the big toe joint into its extreme range of motion. Don't do push-ups with that toe in an extreme range of motion where you're pulling it all the way up. I think that's kind of the gist of that one.
It doesn't mean don't do them. It just means modify how you do them.
Modify.
Yes.
Single leg split squats instead of a lunge. Do a push-up on a yoga ball or something like that.
Yep. Lunges they're good core exercises. They're not big toe joint exercises. So do them without the big toe. They'll actually be much harder and much more effective.
Perfect. Well, we wanted to respect everyone's time. We tried to finish in 45 minutes. Hope you all find this valuable. Certainly we'll stick around if anyone else has any quick questions, but thank you all for participating. Thank you, Dr. Feldman, Dr. Saviet, Dr. Kellner. Hope you guys enjoyed. If we can help in the office, please let us know. Okay, have a good night.